US-guided anterograde treatment of biliary stones following Roux-en-Y gastric bypass. EACP in patients with altered anatomy is technically demanding and often a time-consuming procedure requiring either deep enteroscopy for retrograde access to the bile duct or surgical gastrostomy allowing access to the papilla. US provides a new platform for endoscopic interventions. We describe a novel technique of US-guided only access and removal of stones without need for retrograde access to the bile duct in a series of 6 patients with prior Roux-en-Y gastric bypass, referred for measurement of bile duct stones. All patients had positive MRCP studies for biliary stones. The procedure begins with US-guided transhepatic puncture of the left cystine using a 19-gauge needle. In this moment, the stylet is removed and bile is aspirated through the FNA needle. After confirming bile aspiration, contrast is injected, and an anterograde cholangiogram is then obtained. A guide wire is then inserted and advanced through the CVD across the ampulla into the duodenum. A catheter is inserted over the wire for tract dilation and is advanced to the duodenum. Contrast is injected to confirm correct positioning. Anterograde sphincteroplasty is performed using a 10, 11, 12 mm CRE balloon. An extraction balloon is used to perform delicate sweep movements to push the stone across the papilla into the duodenum. Final cholangiogram reveals successful stone removal. In this case, we appreciate a large distal CBD stone. A wire was advanced into the duodenum and an anterograde sphincteroplasty was performed with a large balloon, after tract dilation. After sphincteroplasty, the dilation balloon is then used to push the large stone into the duodenum. In this third case, even though a wire was successfully advanced into the duodenum, tract dilation to allow advancement of the balloon catheter was not achieved. Enteroscopy was then performed and stone removed accomplished with a rendezvous maneuver. US-guided anterograde stone removal can be summarized in 5 steps. Puncture of the left intrahepatic system using a 19-gauge needle, advancement of a guide wire across the ampulla, catheter dilation of the access tract, anterograde balloon sphincteroplasty, and anterograde stone advancement across the ampulla using a balloon. US-guided cholangiography was successful in all cases. Anterograde stone removal was achieved in 4 of the 6 patients. 2 patients required enteroscopy due to failure in achieving adequate tract dilation. In 1 patient, a cystic duct stump stone was found. The overall success rate was 67%. The mean procedure time was 85 minutes. The mean balloon sphincteroplasty size was 12 mm. 1 patient developed a subcapsular hematoma that required hospitalization. This hematoma resolved without further intervention. In conclusion, direct US-guided treatment of biliary stones appears feasible in patients after gastric bypass. This technique may be an attractive treatment option compared to other available methods.